Good afternoon, everyone. My name is Bushra Sulaiman, and I am a final year medical student from Arabian Gulf University. My presentation today will be about Parkinson's disease. In this presentation, I'll be covering the definition, epidemiology, etiology, risk factors, pathophysiology, clinical features, diagnosis and differential diagnosis of Parkinson's disease, pathological findings, and as well as management. So Parkinson's disease is a neurodegenerative disorder of the with progressive depletion of the dopaminergic neurons in the substantia nigra pars compacta, which is part of the basal ganglia. The age of onset is usually after 50 years, and it is the second most common neurodegenerative disorder after Alzheimer's disease. And there are many risk factors to Parkinson's disease, including old age, family history of Parkinson's disease, and history of traumatic brain injury. So the etiology of Parkinson's disease is usually idiopathic. However, there are some mutations can contribute to the development of this disease, such as the alpha-synuclein and mutation in the GBA gene, LRRK2, and the PARK2 gene. Also, there are secondary causes that can lead to the development of Parkinson's disease, such as the medication, which are the most frequent cause, drugs with anti-dopaminergic effects, such as the antipsychotics, haloperidol, chlorpromazine, and antiemetic, such as metoclopramide, reserpine, and alpha-methyl-dopa, can lead to the development of Parkinson's disease. Other toxins also can contribute to that, such as MPTP, carbon monoxide, cyanide, and manganese. Also, any structural lesions around the basal ganglia, such as trauma, tumor, abscess, and infarct. Also, survivors of encephalitis can develop post-encephalitic Parkinsonism. No matter what the cause is, Parkinson's disease derives from the progressive degeneration of the dopaminergic neurons in the substantia nigra, leading to dopamine deficiency at the respective receptors of the striatum, with interrupted transmission to the thalamus and to the motor cortex, leading to the motor symptoms of Parkinson's disease. And usually the indirect pathway of the basal ganglia is affected. And usually patients with Parkinson's disease, they have also depressive symptoms, and they contribute that to the serotonin and noradrenaline depletion. The clinical features of Parkinson's, we have four key features: the tremor, bradykinesia or akinesia, rigidity, and postural instability. So the tremor, we have patients who have resting tremor, and this is usually the presenting symptoms. Usually the characteristic of the tremor is bell rolling tremor, as if the patient is rolling a bell between his index and thumb fingers. And usually the tremors is noticeable in the hands, and they increase with stress, and they can improve with actions. And for the bradykinesia, they usually have shuffling gait and micrographia or small handwriting. And rigidity is characteristic for patients with Parkinson's. And usually the rigidity is interrupted with the tremor, leading to the producing the cogwheel rigidity, as you can see. And usually the rigidity manifests before the tremors. And the late findings of Parkinson's disease is the postural instability. Usually patients, they have problems with balance, and usually and they can't fall. They have also difficulty initiating the first step and walking with small shuffling steps, stoop posture, and decreased arm swing. Other features include hypomimia, or the mask-like face, or the expressionless. They have dysarthria, dysphagia, dementia, and advanced disease, leading to impairment of their cognitive function. They have also autonomic dysfunction, such as the orthostatic hypotension, constipation, increased sweating, and oil skin. They also have personality changes. They are usually apathetic, they're dependent on others, and they experience depression, which is very common and significant in these patients. Usually the clinical features follow a progressive course, and usually the course is more than 10 years. The motor signs are usually unilateral at onset, but they can progress to the contralateral side, and usually they are asymptomatic, and they are more pronounced at one side more than the other. And as I said, there is like a certain features, preclinical stage with non-motor signs that can precede the clinical phase or the onset of the motor signs, such as constipation, anosmia, or the loss of smell, sleep disturbances such as limb sleep behavior disorder, restless leg syndrome, and excessive daytime sleeping, and mood disorders such as depression and anxiety. We have this picture that illustrates majority of the signs and symptoms of patients with Parkinson's disease: the mask-like face, the reduced arm swing, the stool posture instability, tremors in the hand, micrographia, and bradykinesia. And there is a mnemonic that we can remember it, which is Parkinson's traps the patient, which stands, the T stands for tremor, R for rigidity, A for kinesia, and P for postural instability. You can see this is a video of patient with Parkinson's disease. The next video shows the bell rolling tremor in patients with Parkinson's disease. Moving to the pathology, so Lewy bodies are a key neuronal findings in the brains of patients with Parkinson's disease. They are aggregates of misfolded alpha-synuclein within the neural cell bodies, and usually they appear as histologically as intracellular hyaline eosinophilic globules, as you can see on the right picture. And the loss of the dopaminergic neurons, they cause depigmentation in the basal ganglia. You can see on the left side picture the normal substantia nigra and the one with patients with Parkinson's disease. And for the management, Parkinson's disease has no cure, and the goal of the management is to delay the progression of the disease or to relieve the patient's symptoms. So the pharmacotherapy is usually initiated when the symptoms start to cause functional impairment. And we have also to manage the associated symptoms such as the depression and dementia. So we have different classes of drugs used for Parkinson's disease. The drug of choice is the levodopa carbidopa. So the dopamine cannot cross the blood-brain barrier. However, its precursor, which is the L-dopa, can cross the blood-brain barrier, and once it's in the neuron, it is converted to dopamine by the dopa decarboxylase. However, the dopa decarboxylase is also present peripherally, where it's where it converts the L-dopa to dopamine. So to prevent that, we can prescribe carbidopa with the levodopa, which is a dopa decarboxylase inhibitor, which inhibits the peripheral conversion of L-dopa to dopamine. However, the major side effects of these drugs is the dyskinesia and the hallucinations, along with nausea and vomiting, and the on and off phenomena, which leads to fluctuations of the patient's symptoms throughout the day. We have other drug, which is the amantadine, which is an antiviral drugs. These drugs increase the endogenous production of dopamine. Other class of drugs is the COMT inhibitors, which inhibits the conversion of the L-dopa into the 3-OMD, and that will this drug is used as long with levodopa, and very similar to this mechanism is the MAO type B inhibitors, which inhibit an enzyme that metabolizes dopamine. Another class of drugs is the dopamine agonists, such as bromocriptine, which stimulates the dopamine receptors. And we have also another class, which is the anticholinergic drugs, which can be used to improve the tremor and the rigidity, because we have a relative increase in the acetylcholine compared to the dopamine. Coming to the diagnosis, so Parkinson's disease is a clinical diagnosis. You can consider the diagnosis in patients with the Parkinsonism, such as the tremor, rigidity, akinesia, and the postural instability, and the definitive diagnosis requires post-mortem confirmation that can help you with the diagnosis, such as tremor and development-induced dyskinesia and disease. And the last resort is surgery with the deep brain stimulation. They can plant stimulating electrodes. The indication of this procedure is severe motor symptoms or refractory tremor despite treatment, and decrease if we want to decrease the dosage of medication because of adverse effects. Usually, the prognosis of patients with tremor as the major symptoms of the Parkinson's disease, they have a better prognosis than those who have bradykinesia as the prominent finding. We have also the Parkinson plus syndrome, which is Parkinson's symptoms with other features. We have the Parkinson's with the vertical gaze pulses and supranuclear palsy, and we have the olivopontocerebellar atrophy, which is Parkinson's with the prominent ataxia, and the multiple system atrophy, which is Parkinsonism with the prominent orthostatic hypotension. And all of them, they share a common things that the relative lack of response to levodopa-carbidopa. And there is a recent research where they discussed the emerging evidence of the Parkinson pandemic, where it says that the number of people with Parkinson's disease have doubled to over 6 million between the period of 1990 to 2015, and it might also double again in 2040. And this might be the most driving factor is age. So as the population is aging, more people are being diagnosed with Parkinson's disease. And we have also other risk factors, such as declining smoking rates, as smoking has have a protective role in Parkinson's disease and increasing industrialization. These are my references, and that brings me to the end of my presentation. Thank you for listening.
Mm-hmm. So if we go in.